it quick and short. Good evening, doctors and colleagues. Welcome to today's meeting on post-insertion problems in complete dentures. This article was published in India in December 2020. It's a new article. And okay, why I can't, yeah. People lose their teeth and turn from dentulous to edentulous state. It is hard to eat, chew, talk, and even the facial appearance will look different. It is time to have a pair of new complete dentures. After going back and forth to the clinic and getting all the steps done, a new denture is delivered and the patient is now experiencing and adapting to it. What problems the patient will face? What are the complaints we will hear during the follow-up appointments? This is what we will be discussing today. It is important to prepare the patient prior to the treatment. This will motivate the patient to overcome these limitations. A complete denture wearer will look towards eating and chewing easily, a natural look and good aesthetics, to be able to speak and pronounce letters efficiently, and to feel comfortable and pain-free. Different authors classified the post-insertion problems. Here are all the classifications combined into the following points: instability, loose, non-retentive dentures, lower denture rise when mouth is opened, sore spots, gagging, feeling of space in upper denture, phonetic problems, can't chew food properly, loss of taste, clicking while eating or talking, tenderness when swallowing, food accumulating under denture, saliva under denture, dislodgement when drinking, drooling of saliva at the corners of the mouth, excessive bulky dentures, cheek, lip, or tongue biting, halitosis, xerostomia or dry mouth, excessive salivation, peculiar or odd taste, TMJ problems, or burning sensations. So these are the problems we are going to discuss. We will be discussing each problem separately and how to treat it. Once the problem is evident and the cause is known, it can be treated in a systematic way. It is very important to take a good history along with careful oral examination. Doing this, we will reach our diagnosis and hence treatment plans can be made and followed appropriately. Now let's start with the maxillary denture problems. One of the problems is maxillary denture dislodgement while in function. The reason...
I'm sorry, Dr. Sabi, can you please mute yourself?
Thank you.
Okay. So maxillary denture dislodgement while in function. The reason or cause could be extension of the denture to the hamular notch area. Hamular notch is the region between the tuberosity of the maxilla and the hamulus of the medial pterygoid plate where the denture should end. Another reason is inadequate relief of the frenal attachment. Excessive thick denture bases over the distobuccal alveolar tubercle area, leaving insufficient space for the forward movement of the anterior border of the coronoid process. Another reason could be the anterior maxillary teeth placed far in the anterior direction or maxillary posterior teeth placed far in the buccal direction. Posterior palatal seal area placed far in the superior direction, resulting in displacement of soft tissue, therefore displacement of the maxillary denture. Occlusal disharmony. Now, maxillary denture dislodgement at rest. Why? Why this can happen? An underfilled buccal vestibule or lack of border seal Excessive formation of saliva leading to less retentive denture, or on the opposite side, xerostomia. Another problem with upper denture is falling or dropping while talking. Reason are again inadequate posterior palatal seal, poor peripheral seal, or occlusion that is not balanced. Now, upper denture or upper complete denture that tips on incisal pressure, the reason could be pedunculus or loose tissue present over the ridge, or insufficient posterior palatal seal. Now we will move to discussing about lower complete denture problems or mandibular denture problems. Dislodgement of lower complete denture during function is related to extending phalanges in the lateral direction beyond the external oblique ridge buccally, or overextension of the lingual phalanges, placing the occlusal plane too high, causing dislodgement when the tongue tries to handle the bolus of food, and improper contour of the polished surface. Coming to dislodgement during tongue movements, poor border seal or overextended lingual phalanges, insufficient clearance to lingual frenum, or occlusion that is not balanced. Now, one of the most common complaints associated with new dentures are sore spots. There are many reasons why sore spots occur. It could be inadequate coverage of the edentulous ridge with the denture, or overextended phalanges in the overextended phalanges in the vestibular region, excessive vertical dimension of occlusion resulting in overall redness of the edentulous area, presence of sharp bony projections from the presence of the sharp bony projections from the edentulous ridge, or presence of thin atrophic mucosa over the edentulous ridge. Presence of tori that was unrelieved prior to treatment, unfavorable habits such as clenching of teeth, local infections, bacterial or fungal. Treatment of sore spots is first by finding the cause. The denture should cover the entire edentulous ridge. Any overextended phalanges should be reduced, smoothed, and polished. Vertical dimension of occlusion should be adequate, not excessive. Any sharp bony projection need to be smoothed, tori relieved prior to treatment. Any local infection should be treated with the appropriate medication, and discontinue wearing dentures for 24 to 48 hours. This is what we usually advise the patient. Now, gagging. Gagging can be a psychogenic, somatogenic, or related to dental reasons. Psychologic starts in patient mind without a trigger, and it is difficult to treat. Somatogenic or physiologic is initiation or trigger from the body to a new denture, and it can be treated. The dental reasons can be overextended denture base in posterior palatal seal area, poor occlusion or lack of retention, and excessive vertical dimension of occlusion. Treatment of gagging is by determining the cause, removal of any biologic or mechanical factor that may contribute to the problem. Prescription of hyoscine or scopolamine, which are anticholinergic drugs for treatment of motion sickness and nausea. They also decrease the saliva production. Or we can prescribe atropine, an anticholinergic drug that causes decrease in saliva secretion, and it will depress the central nervous system. Both hyoscine or atropine are prescribed with a sedative drug at the beginning or initial period of the denture use. Acupuncture, similar to acupressure. It is to depress the stimulation of the central nervous system to gagging. And if the above didn't work, we will refer the patient to a psychiatrist. Another problem is feeling of space under maxillary denture. Usually is a result of resin shrinkage during denture processing in the lab. If there was a history of anterior traumatic occlusion resulting in paresthesia of the nasopalatine nerve, the patient also will feel a space under the maxillary denture. Now let's go to problems related to phonetics and speech. Usually it is related to excessive vertical dimension of occlusion or too narrow airspace on the anterior part of the palate or too broad airspace and the anterior part of the palate. Improper positioning of the anteroposterior maxillary teeth and insufficient lip support can cause phonetic and speech problems as well. Treatment is by first finding the cause. Shushing or lisping can be related to excessive vertical dimension of occlusion. A problem with airspace can be adjusted by removing some resin in increments behind the anterior teeth or adding wax in 1 millimeter increment anterior and lateral to palate area to ensure proper tongue contact. Now let's move to problems related to inability to eat food. Patient expectations sometimes are too high when wearing new complete dentures, that he or she want to eat every food they enjoyed before losing their teeth. Or poor muscle control could be the reason why patient cannot chew food. Treatment is by boosting up the patient psychologically or by changing the occlusal scheme by going to lingualized occlusion or the use of lingual bladed teeth. Another problem is taste loss, and this is usually as a result of atrophy of the taste buds in old age patients, and most of the cases it is psychological. Clicking sounds while eating food. The causes are overextended complete dentures, premature contacts, or excessive vertical dimension of occlusion. Treatment, again, is by determining the cause first. Occlusal equilibration by clinical remount of the complete denture, relining or rebasing if the denture fit is not appropriate. Now, pain during swallowing, mainly due to overextended distolingual phalanges, corrected by reducing the overextended area. Drooling of saliva at the corner of the mouth. It is caused by hypersalivation or closed vertical dimension of occlusion or poor muscle control. How can we solve this problem? First, identify the cause. If it was due to closed vertical dimension of occlusion, then a new denture should be made to control the saliva drooling. Another attempt is by making the denture phalanges a bit thicker at the modulus area. The modulus area is where the muscles meet at the corner of the mouth. Now, cheek, lip, or tongue biting. Why cheek biting happens? The reason is due to an inadequate overjet between maxillary and mandibular anterior teeth, or loss of vertical dimension of occlusion. Because of that, the cheek tend to occlude between the occlusal surfaces of the denture. Treatment is by increasing the overjet by reducing the buccal surfaces of lower posterior teeth. Tongue biting is caused by lack of lingual overjet and usually treated by reducing the upper molar palatal cusps. Lip biting due to poor neuromuscular control in old patients. Halitosis, it is related to poor oral hygiene, patients not cleaning the denture regularly, or a patient is medically compromised and can't take care of the denture. Xerostomia, it is related usually to patients taking medication, such as antidepressants, or related to geriatric degeneration of the salivary glands, vitamin A deficiency, or renal diseases. Xerostomia causes difficulty in eating and swallowing food. Patients are advised to drink water between meals and with meals. Prescription of sialolox can be helpful. Artificial saliva or mouth rinses are also helpful. Now, excessive salivation can be a problem in retention of complete dentures, usually experienced at the initial stage of wearing a new denture and subsides by itself. TMJ problems occur as a result of spasm in the muscles of mastication seen in patients who wear dentures for a long term. Loss of vertical dimension of occlusion can cause TMJ problems, and if not treated, these problems lead to pain in the ears, TMJ, muscles of mastication, clicking of TMJ, pain while opening and closing the jaw, or midline deviation. Treatment: if the cause is loss of vertical dimension of occlusion, a new denture must be fabricated. To relieve pain, advise patient to stay on soft diet and use hot packs. Muscle relaxants is advised. Now, last but not least, burning sensation. Burning sensation is related to ill-fitting dentures or poor denture occlusion, candida infections, or nerve compression. Treatment is by identification of the cause. Patients are advised not to wear dentures for 2 to 5 days at least. Rinse with water, warm water or saline 2 to 3 times daily. Antifungals in case of candida infections. And patients are advised to go for new dentures if the case was related to candida infection. In case of nerve compression, surgical management might be required. In conclusion, a thorough knowledge of different factors required for the fabrication of complete denture is must before entering the post-insertion checkup. Patients should always be recalled so that the remaining complaints can be eliminated. Thank you for listening. Hope you enjoyed it.
Thank you very much, Dr. Nagham. Are we okay to launch the poll, the polling function? Do you want to jump into the questions?
Yeah.
All right. All right. Do you see the questions?
Yes,
All the questions or just one of them?
just one.
All right.
I can see them all.
I think from the participant sites, they only can see the first question. But I don't see any of the answers coming in, which is why I'm asking to see everything's going all right. Yeah, no answers are coming in from my end.
Submitting answers. You should be receiving something. What else?
Yeah, nothing. Must be an
Maybe
issue
you'll
here.
receive everything after the poll is done. Because there's no submit. There's only next and previous.
Okay, okay. So is everyone answering the first question first, or are you answering all 10? Do you have an option to answer all
Answering
10?
all 10. All 10.
All 10. Oh, okay, okay. Then we'll wait a couple of minutes.
Yeah. Thank you, Montez.
No worries. Already have our first set of answers. All right, they're coming in. These are the people who come out the first out of the exams, aren't they?
I'm sure that's Dillon.
No, I'm actually taking my time answering these.
Double checking your answer. You can't go wrong, man. Dr. Ali says that's him. So he's the first person
Wow.
out of this test. It'll be interesting to see how well you did.
No pressure, no pressure.
We'll wait 2 more minutes and then it's pencils down.
Just out of curiosity, what happens with these results?
Afterwards, we'll give the opportunity to Dr. Nagham to go over the questions and answer them one by one. This is just Dr. Sally can jump in here, but this is just for recreational.
This is only
purposes.
for CE, yeah, for CE verification.
Yeah, there you go. That's what happens with the questions.
And there is a question from Dr. George. Patient is not happy with her new dentures, does not like the look of anterior teeth, and patient says her bite is off. What can be done other than remake the denture? Dillon.
I can answer this.
Yeah, Dr. Hassan, give it a go.
Sure, go ahead.
Okay, fine. I can answer that one. You see, I know everything. I really think first thing, Dr. George, does the patient comfortable with the vertical dimension of occlusion? Is the patient very comfortable with the adaptation of the bite? Is there retention, stability, and vertical dimension of occlusion? Are they good? I have no answer. So if assuming the answer is yes, then the problem is in the teeth, right? So the problem is two things, is the way that the teeth are set and the registration, right? So I think you have to put it back into remounting, you're right, and you remove up the teeth, right? And you use up another occlusal basis, take up a registration again, set up the teeth, try again, and just put up a new teeth. Dillon, do I pass?
Yeah, fair enough. That's what I was going to say. Probably the easiest way to troubleshoot that if we're doing it the conventional way. Definitely.
Yeah. Or you can just do a new denture.
Fair enough. I mean, with all this digital stuff too, you could scan that existing denture in, take your new registrations, print a new try-in to assess that everything's okay, and then follow through with the final prosthesis.
Right. And if the and the problem arises if the vertical dimension of occlusion, that it's get more complicated, right? So they're gonna have to open up your or close up your pin on your articulator and all that stuff, right? That happens if that is the case.
Exactly. Exactly.
Yeah.
And even in that case, if your video is off, you'd still troubleshoot it the way you said. You know, you can strip off the teeth and take your new registrations as is.
Right, right, and start again. Yeah, but the only thing is that your pen over here is going to be a new pen versus exactly the old pen that it was there, right? So that's
exactly
that's yeah. Sally, do I pass?
Of course.
Okay, fine. Oh my gosh, that's good.
Does he always pass?
Sometimes, not all the time.
Most of the times.
Sometimes, not all the time.
Majority of the times, not always.
Yeah, not all the time.
Okay, we have 16 of 20 participants. Are you expecting the 4, or should we end polls and publish the results?
Yes, you can end the poll and publish the results so that we can take the answers. And guys, bring your questions in.
Sorry?
Bring your questions. Oh, sorry.
No, I said I was driving, so there is no way for me to be, to do that. Dr. Fatin is calling me.
All right, you have the results in front of you now. Dr. Nagham, do you want to go over the questions with everyone? Or Dr. Sally?
Hello. Hi. Hello.
Sorry, Dr. Sen, are you speaking to us or are you on the phone?
No, I'm talking with you. I mean, Dr. Sally is going to take care of the questions, right? Because I'm driving.
No, Dr. Nagham is. Where is she?
Oh,
I'm here.
She's feeding the baby.
Yeah.
Oh. Feeding the twins.
All right. So we will go over every question.
Yes.
Okay. What causes an upper denture to drop while talking? Actually, it's all of the above. Inadequate posterior palatal seal, an occlusion that is not balanced, or poor peripheral seal.
Okay, I want to ask a question. What is the definition of the posterior palatal seal? Did we, I mean, I wasn't there from the beginning. Did you mention the anatomy?
No, anatomy is no.
All right. Does maybe Dr. Sally, Dr. Nagham, do you want to elaborate?
It's the butterfly between
the junction
the
between the hard and soft palate.
The soft and hard palates,
Right.
That is for the pass. Did I pass, Dillon?
100,000%. Yeah. A+ all around.
And it's depressible tissues, and that's the whole idea. That's why when you take your impression, you're always going to have to allow for that because it's a depressible tissues, right? This is one of the things as well that I really still remember. See, I was taught dentures well. That's the only thing. I was taught dentures well. That's one thing that I was taught very well, dentures. Okay.
All right, let's go to
Still,
the
still I don't like it. Still I don't like it.
most of us. All right, shrinkage of the denture resin during processing leads to, the answer is B, leads to space in the maxillary denture. Question number 3, clicking sound while eating food is due to insufficient vertical dimension of occlusion, true or false? It is false. It's related to excessive vertical dimension of occlusion. Excessive vertical dimension of occlusion can cause sore spots, problems in phonetics, clicking sounds while eating. The answer is all of the above. Going to number 5, following insertion of lower complete denture, a generalized soreness over the entire mandible alveolar ridge can cause. The answer is C. What? No, sorry. What? Following number 5. Yeah, the answer is C, inadequate interocclusal distance. Now, number 6, which of the following structure affects the thickening of the phalange of the maxillary complete denture? It is the coronoid process. Number 7, a new set of complete denture should be made in case of TMJ problem related to vertical dimension of occlusion. True or false? That's true. Physiologic tension in complete denture wearer can cause excessive salivation or xerostomia, lip biting, sore spots, A and C. The answer is A and C, excessive salivation and sore spots. Number 9, burning sensation in complete denture patient result from compression of nerve. True or false? The answer is true. Number 10, tori should not be relieved before starting treatment, instead used for increasing retention of the denture. That's very easy, of course, it's false. Yep, that's it.
I missed number 8. That was wrong for me.
Oh, okay. I
Okay.
made the answer the question so easy. Yeah.
Yeah.
Thank you for your honesty, Dr. Sally. Anyone have any questions before we stop sharing the results?
I do. Dr. Nagham, you mentioned in one of the slides to reduce gagging, you can utilize acupressure. Has anyone ever applied that in clinic and it worked?
Not me.
No, not me. I know it works in back pain, hands pain, leg pain, but in gagging, no, I haven't seen that before. But it was there in the article, so it seems they've tried it.
Yeah, I'm gonna give that a shot. That's new to me. I've seen some stuff floating around on the online forums, and this is all out of America, so I don't know how legal it is out in Canada, but doctors have been placing a number 8 or 10 endophile within the middle of the chin, slightly impinging into the soft tissue to reduce gagging reflex. And it seems to be working quite a bit based on the feedback that I'm seeing online. But like I said, I don't know how legal that is out here in Canada. I wouldn't personally do that.
That's interesting.
Dr.
Mu'taz,
Sally, I'll
joined
send you a
from-
screenshot regarding that so you can take a look at it. I'm not suggesting you guys do it, but it's an interesting concept that I've seen recently.
Please do. Mu'taz, I'm signing in from my cell phone and I can't see the chat. Are there any other questions on the chat box?
No questions in the chat box.
Okay, I have a question for Dillon. What is the most common post-insertion problem that you had to deal with?
Oh, I can name a few. So with the maxillary arch, thickening of the palate towards the posterior seal causes a lot of gagging. So we want that area to be nice and thin. Another thing on the maxillary arch around the labial frenum attachment that can impinge from the denture acrylic onto the tissue. And within the 1-3-2-3 area, if they have a really bold canine eminence, that causes a lot of issues, especially upon insertion of the denture. On the mandibular arch, the mylohyoid region around the S curve, if they have a really deep undercut, can cause issues with insertion and can cause issues once they occlude into it. Over time, they'll get used to it, but for the first 6 to 8 weeks, it can be really tough for the patient. Lower arch as well in the, if there is mobile tissue, that causes a lot of pain with impingement, and especially if there is a large tongue causing that denture to flip up and move around, just the instability of that is an issue. Another common problem that I've found is pressure just all around, whether it's on the maxillary ridge or mandibular ridge, and that can be just from an excessive occlusal pressure, which is just doing a little selective grinding on certain aspects that you find high spots in. And that's just strictly for complete dentures. Partial dentures, it's a little bit different.
That's nice. I also have another question. How do you discuss dentures with your new denture patients to keep their expectations realistic? Like what do you mention? What do you focus on?
Well, if it's someone that is dentate going into a dental situation, so they're going through a full arch process and it's a full clearance, typically I start with, what are you looking to gain out of this treatment modality? Are you looking to keep the same sense of normalcy with your natural teeth, with your prosthetic teeth? And then we build from their expectations there. If they say yes, then immediately we start talking about implant treatment, because if they're looking to keep that same expectation of normalcy, they're not going to get that with a complete removable denture. If it's just someone that is okay with no implants going into an edentulous situation, they have to understand the limitations behind foods that they can eat, speech issues, as well as the aesthetic issues that can arise with just having the flange of a denture bulk up the facial aesthetic portion. I hope that answered it.
Of course. And every denture patient is unique, especially with their expectations and the limitations that and challenges that we have intraorally and psychologically.
Yeah, 100% agree with that. Definitely.
There is a
yeah.
There is a notification. Yeah. You can go ahead.
Dr. Ali, I see your question there. Are there any advantages or long-term effects of patients using denture adhesives on a daily basis? Any disadvantages? Sorry. Yeah, disadvantages is the zinc within the denture glue can cause issues within the gastrointestinal tract, which can really upset a patient. In regards to that, the taste of denture glue is not very friendly, and then the hygiene components of denture glue are not very friendly as well. So the disadvantages, outweigh the advantage of keeping the denture in. But like Dr. Sally said, it's all patient-based, and if you're educating them appropriately, they'll follow the instructions. Otherwise, they'll glue these dentures in and keep them in for a couple of days, and the result of that is not very fun. And just to follow up, I try to avoid my patients utilizing denture glue. I mean, for patients in an economically compromised position, of course, that's their only option. But if you can, either reline that denture to make it better fitting, or even suggest implants, that'll be the best option for them, because utilizing denture glue does not increase the quality of life for the patient as much as they would expect it to.
Thank you, Dillon. Are there any more questions? Or are you guys
because I'm at the office right now. I have to get a question.
Okay, so, sure.
Okay, what would you do with a patient who has got candida? What are the medication, the regimens Dr. Nagham Dajani, the presenter.
Yes. We use antifungals.
Oh, really? Okay, that's very deep. What type of fungus?
Canalog.
What is that? What do you start with usually? I personally, what do you start with?
We can start with first mouth rinses.
Mouth rinses, yes. What is it? What is the most common one? Common things happen commonly, right?
Yeah.
So what's the common ones that you do?
Like antifungal, you mean? Seems I forgot.
Starts with an N. Starts with an N.
Nystatin.
Yes. How do you write the prescription? You're not going to give nystatin. That's it. You're going to have to write the prescription for it. Dr. Fatin is going to tell you.
I actually have it right here. I have to cheat.
She has to cheat. Dr. Fatin will tell you.
So, a nystatin suspension, 100 units per milliliter, dispensing 200 milliliter, and then swish with 5 milliliter and swallow 4 times a day until finished for 10 days.